proprotein convertase subtilisin, kexin type 9, or PCSK9, is a key regulator of LDL receptor expression on the surface of hepatocytes. Circulating PCSK9 binds to LDL receptors with high affinity. When circulating LDL binds to the LDL receptor PCSK9 complex, the complex undergoes endocytosis into a clathrin-coated vesicle in the hepatocyte. However, with PCSK9 bound to the LDL receptor, the entire complex is targeted for lysosomal degradation, resulting in LDL receptor degradation. Therefore, PCSK9 can decrease the expression of surface LDL receptors. Thus, fewer LDL receptors are available on the liver cell surface to bind circulating LDL-C, and circulating LDL-C levels rise. Inhibiting the function of PCSK9 is a novel strategy that has the potential to lower plasma LDL cholesterol levels. Praluent is a monoclonal antibody inhibiting PCSK9 by preventing it from binding to the LDL receptor. With decreased PCSK9 activity, LDL is able to disassociate from its receptor within the hepatocyte, allowing the LDL receptor to be recycled back to the cell surface where it can bind more LDL, thus decreasing LDL-C levels. Praluent, which binds to and inhibits PCSK9, is a novel therapy that offers the possibility to lower LDL-C levels. Please see full prescribing information.
Good evening, everybody. We are streaming now from Egypt. We are streaming a very new event in the cardiovascular horizon. It is one of the Egyptian Association Vascular Biology and Atherosclerosis Association activities. It is a case box, CardioGO case box. And I think this event will be interesting for a lot of intervention cardiologists, for a lot of imagers, for a lot of cardiologists, as it will be interactive, interesting cases, and also educational step by step. Today, we will start the first wave, and I'd like to welcome you all, to welcome all the professors, the speakers, to welcome all the panelists, the eminent panelists with us today. And also, I'd like to thank the sponsor companies, Sanofi and Medtronic, for this event. And I'd like now to leave the mic I'd like also to mention that this event is a joint meeting with the prestigious JACC Case Reports Journal, in which the Professor Julia is the chief editor. So I will leave the mic now to Professor Ashraf Reda to give us a brief about the meeting. Professor
thank you, Dr. Said. Thank you, Dr. Said, and actually it's a pleasure. Actually, it's a pleasure for me to introduce this important webinar, and I'd like to welcome Dr. Julia, the chief editor of JACC Report, and the eminent international and the national speakers of today. I would like to send a special thanks to Dr. Said Farag and Dr. Julia for preparing this cooperation between IAVA and JACC Report, and I hope it will be interesting for all the participants. And if you allow me to introduce the program of today, today we will have two sessions. The first session will three cases, TAVI or TAVR cases, Hazem Khamis, Jose Carlo Moreno from Spain, and Julia Grabsa, our moderator of this session from UK. We'll have in the first session panelists Ahmed Sayed, Hamdi Sulaiman, Julia, Nabil Farag, and Mohammed Salim. I leave now the mic to Dr. Julia to say a word for you before starting the first session. Dr. Julia.
Thank you, Professor Ashraf Reda. Thank you, my friend El Said Farag. I would like to thank you for your attendance. It's a great honor for us to be here representing JACC case reports. I would like to thank also my colleagues, Dr. Jose Carlo Moreno Samos from Spain, Dr. Joel Giblet from UK, and we have panelists Dr. Mohammed Ansari, Dr. Ali Elzeni, and Dr. Mohammed Akhtar, who will join us discussing the cases. Just a brief message to your audience that JACC case reports is almost 1 year old, and we have accepted approximately 3,500 cases last year. Jose, Joel, and the rest of the people, we work all together as a family. And I would like to invite you to submit your manuscripts. We accept educational or rare cases, but they are all as per JACC journals, and as you know, they undergo peer review. But we are here to encourage people to work with us. We are here to help as much as possible to create an educational tool. Thank you very much once again for this wonderful invitation.
Thank you, Julia. And I think now we'll have a 30-second break to and stay with us and come back for the first case with Professor Hazem Khamis. أنا مش شايف دكتور حازم هو فين.
Rahim. It's a real pleasure to be part of this event. Thank you for Professor Ashraf Reda and Professor Said Farag. Today I will give a case in TAVI in acute coronary syndrome. The format of the case will be, I will present the clinical scenario, the CT, and I will stop for a few minutes to discuss the case, and I will ask every one of the panelists for sharing his opinion. So it will not an open discussion for all the panelists during the case. It will be specific for everyone. So my colleague Nabil Farag, Ahmed Al-Sayed, Hamdi, Sulaiman, all Mohammed Salim, Dr. Ashraf, Dr. Said, and Julia, it will be very specific questions. My case today is 84 years old female, presented with severe aortic stenosis, twice flash pulmonary edema, and there is residual NIHA class 3. She is a small woman with height, body weight, and body mass index. She had hypertension, insulin-dependent diabetes, dyslipidemia, stable coronary artery disease, chronic kidney disease, moderate COPD, paroxysmal atrial fibrillation, and one attack of transient ischemic attack. Socially, she lives at home with her son, frail, with mild cognitive impairment. The lab investigation, normal hemoglobin, creatinine 2.7 milligram, estimated GFR 38, CRB is normal, the ProBNP elevated, and the transthoracic echocardiography, the Vmax 4.2, aortic valve area 0.7 centimeter square, the peak gradient 70, mean gradient 40. She is in sinus rhythm, moderate left ventricular function, moderate left ventricular hypertrophy. The ejection fraction is 45 with mild pulmonary hypertension. The carotid Doppler mild bilateral disease. This is the finding of the CT. The annular measurements, the perimeter is 69, and the area 379. The supra-annular area, the sinus of valvular diameter, and the joint point. These are the measurements from the CT. The coronary height is feasible for the TAVI, the RCA 14, the left coronary 12. The peripheral axis good. There is some tortuosity with some calcification for the right common iliac and left common iliac, but the diameter is 7.4. The risk stratification of this case, the Euroscore 2 is 10.7%, the STS score 11.8, clinically CKD, mild cognitive impairment, and frail patients. So anatomically, the transfemoral axis is there. There is some severe calcification on the non-coronary leaflet and adequate coronary height and coronary sinus width. So as usual, we will go to heart team consultation. So Dr. Nabil Farag, what is your opinion for this case? TAVI or surgery? What's them? And this is candidate for TAVI. What is your opinion?
Thank you, Hazim, for this case and for your question. My opinion is this is a high-risk patients, and you know we have many trials, and we are moving towards even a moderate and low-risk patients to undergo TAVI in preference to surgical aortic valve replacement. I think this is an 82 years old with this STS score and Euroscore, which is very high. I think this is a straightforward case for TAVI because of the high risk and her age. And as well, it is a suitable case. You have the femoral axis, which is good for her, in spite of some tortuosity, and the annulus is 22, as I remember. So the mean diameter is 22. So we have the valve size available for this case. So my opinion is this is actually a straightforward case for TAVI, not for surgical aortic valve replacement.
Okay, Julia, what do you think? General anesthesia or local anesthesia and conscious sedation? What do you think?
So as Dr. Farag mentioned, I mean, it's a high-risk case, so I think the patient would need to be reviewed by an anesthetist and then obtain their opinion first. That would be my first comment.
Okay. Ahmed Sayed, what do you think about the vascular access? You will prefer right femoral, left femoral, pre-closure with broglides, prepare it, or what do you do? What do you do in Egypt? Cut down, arterial cut down, or every case you can do broglides? If there is the calcification in the common femoral, can obstacle using pre-closure?
Okay, thanks for the very nice presentation. And again, I do agree with our professor that this is a straightforward case for TAVI, of course. After our team discussion regarding the vascular access from the CT, the picture we showed, I think she's a good candidate for going using a ProGlide. Usually, we use 2 ProGlides for the vascular access in such a lady. She's thin. She doesn't have too much subcutaneous fat, as I understood from her that she's having a lean body weight. But of course, calcium distribution should be properly assessed before proceeding with the procedure. But I think again, mostly she's gonna receive 2 ProGlides as for her vascular access.
Okay, Dr. Hamdi Sliman, while you are doing the transfemoral, how you can do the transfemoral puncture? Sonar guided, X-ray guided. What is the best tool for you to do proper puncture of the common femoral artery?
Yes, I think we always do the puncture of the common femoral artery under the screen in the CAS lab, and recently we were using the sonar guided. It's very important to localize the best point for a puncture in the common femoral and the sweet point is very important. It should be always done under the screen. And while we are doing this, you can do an injection from the contralateral side in order to visualize the vascular axis properly, in order not to miss the common femoral. Sometimes the bifurcation may be high of the common femoral, sometimes low. So it's very important when we use the ProGlide in order to close the artery later on after we finish the TAVI business.
Dr. Jose, it is mandatory in this case with previous TIA to use cerebral protection or not?
Yeah, for sure. I agree. I will use cerebral protection in this patient. Probably with the actual evidence, we should try to use more and more this technique. Is radial access is just with experience, it's just a couple of minutes to deploy the device, and it's worthless. It's important for the patient.
Okay. Dr. Salim, you will do in this case balloon redilatation, or you prefer direct valve implantation? And what are the parameters, what are the requirements to take your decision?
Thank you, Dr. Hazem, for these very good questions. Actually, it will depend if your case comes to the context of combined acute coronary syndrome, and I will do coronary intervention, and then I will put TAVI after that. I think it will be more easy if I will start the coronary intervention before doing TAVI, to start by balloon dilatation to facilitate or making the patient more tolerant to the procedure of the coronary intervention, and making coronary perfusion is much better. Meanwhile, if I don't remember if you mentioned in the echo that there is LVH or marked LVH or not, but I have to be ready if something will occur to put the valve directly, if something occur like acute or severe aortic regurg. But anyhow, I will make a gentle pre-balloon dilatation before the procedure, especially if I will do coronary intervention first.
Dr. Hazem, allow me to comment on the first question to Julia about the general anesthesia.
Okay.
In the last ACC virtual meeting, there was results of a big registry about the complication rates in all the centers in the USA. And I think they noticed that the complication rate is much less when you minimize your interventions, and they called it, I think, minimalist strategy, in which they try to do deep sedation instead of general anesthesia, percutaneous femoral instead of cut down, to make the procedures very non-invasive or very minimal. So, of course, as Julia said, that we should consult the anesthesiologist, but try to be minimalist, as they said.
Thank you, Dr. Ashraf. We can proceed. Unfortunately, in the day of scheduled to do the TAVI procedure, the patient developed severe chest pain, ECG changes, tachycardia, diffuse segment changes in the inferolateral leads, and increased troponin, developed non-STEMI. So I take this case to the cath lab, and I did for her urgent coronary angiography. And just I find nearly significant big OM lesion in the territory of a big OM. The LAD mild calcification, no significant stenosis. The RCA mild ostial lesion and calcification. And as we said before, this is a CKD case, so we need to minimize the contrast. So now, what you will do, Ahmed Sayed, BCI only and BCI and TAVI. I need just one statement, BCI or BCI and continuous TAVI. Ahmed Sayed?
BCI and TAVI.
Jose? Dr. Hamdi Sliman?
BCI and TAVI for me also.
Okay. Dr. Hamdi Sliman?
Yes, the same opinion. Okay.
Okay. If there is anybody will stabilize the patient first with BCI to the obtuse marginal, and then do TAVI in the index days of the hospital, anybody will do.
I think, Dr. Hazem, that I won't say that we should prepare ourselves with a post-antithrombotic regimen in this guy, because if we'll do both techniques, we will need only dual antiplatelet, because with this age the bleeding risk is very high. So I think we should put what post procedure antithrombotic strategy you will follow in this case.
Okay. Dr. Nabil Farag, this case developed suddenly a non-STEMI, and you take this lady to the cath lab. You will do a different puncture. You will do it for the coronary, something like radial approach, or if you did femoral axis approach, there is some preference, right femoral, left femoral, to prepare the other femoral if you will proceed to a TAVI procedure?
Thank you, Hazem, for this excellent question. I like a radial approach in every case, especially in patients with acute coronary syndrome due to the bleeding risk and even in a stable coronary artery disease. Definitely, I will do the intervention through a radial approach, and I can use this radial artery to put the pigtail catheter instead of using bilateral femoral. So I can use the radial artery for the intervention and for a pigtail in the aorta, and the one femoral artery, either the right or the left, based on the choice and based on the tortuosity for the TAVI. I'm voting with post BCI and TAVI in this case because the circumflex looks easy to be done with a very few amount of contrast. As you said, it's a chronic kidney disease. But if it is a complex intervention, it would take a lot of contrast, a lot of time. In this condition, I would prefer doing intervention first, then TAVI later on, maybe 2 weeks later. But in this special case with a straightforward intervention, I will do this BCI first, BCI and TAVI at same setting, radial approach, using this for the intervention as well as to complete the TAVI procedure.
Ahmed Said, there is any preference for the bioprosthesis, balloon mounted, self-expandable, or from these parameters for the CT, for the heights? Do you prefer in this case, after developing acute coronary syndrome, if there is any preference for the bioprosthesis?
Actually, this lady is fit for both self-expandable evolutar and the balloon expandable, let's say, T3. She's fit. She can receive both valves.
Okay, thank you. And we go to to continue the BCI to LAD to the obtuse marginal with just drug-eluting stent. It was calcified lesion. It needs some post-pre-dilatation and post-dilatation, and this is the final result. You may see some residual waste inside the stent, and I will go to the doing a TAVI from the left femoral approach using the amplats. The wiring is somewhat difficult to passing the aorta. Take some time with all tips and the tricks. And after that, I decided, because for the difficulty to passing the wire and the difficulty to maintain your wire, I decided to do aortic balloon valvuloplasty with 20 millimeter balloon, and then at the end I put evolute R valve 26 millimeter. Of course, we took time to optimize the position of the valve to the of course, we have temporary pacemaker as usual, and then we finish with ETAVI bioprosthesis Volute R, and this during the implantation, and I can show the final result of this case. Good deployment. We check after that everything, the hemodynamics, the echo, the transthoracic echo, and everything, and we are happy for this result. I think this is the last picture for this. There is actually no significant paravalvular leak, and I can take conclude my case. This is from slides of Ahmed Sayed as usual. The heart team is at the core of initiation and the continuity of a TAVI program. Selection of patients for TAVI is a careful process that involves all members of the heart team. TAVI has shown to be safe nowadays in intermediate and low risk patient, but careful anatomical evaluation pre-TAVI is necessary for safe procedure. And thank you for your attention.
Thank you, Professor Hazem. Thank you for the interaction. Thank you for strict to time. And I think we'll have 30-second break and come back with Jose Mourinho for the challenging TAVR cases. So stay with us. Dr. Jose.
Thank you very much for the invitation. I'm presenting cases from JACC case reports. So these cases were published last year. Okay, I do not have a conflict of interest. So two main topics. One is device embolization in TAVR, and the other is paravalvular leak after TAVR. I will begin with this case from Jerome Vendrick and co-authors. This balloon expandable TAVR prosthesis dislocates into the ascending aorta. I will simplify the cases in order to have more time for discussion later. The patient is an 82-year-old with severe symptomatic aortic stenosis. Low risk is STS risk of 1.9%, 1.7 of Euroscore, but with history of a rectal carcinoma. So the heart team decided for this patient TAVR. So the procedure was with local anesthesia, with transfemoral access, rapid pacing through the temporary transvenous pacemaker lead. They wanted to use this balloon expandable valve, Sapien 3 of 26 millimeters. And direct to the point, we can see in the white arrow that pacemaker lost just one beat, but then during the deployment of the valve, when it was partial, pop up in the aorta, and then we have a problem. Okay, again, as you can see. So Vendrick and co-authors managed to use the same balloon with was partially inflated to move the valve until the abdominal aorta, and then expand with the same balloon these 26 millimeter valves. They use the previous CT scan to be pretty sure that was the proper diameter for that abdominal aorta. And then after that, they pass it through the previous valve and new Sapien 3 very carefully. They deploy it again under rapid pacing, 180 beats per minute. This second valve in the correct position with very good result. So next day, they performed a CT scan just to control that there no damage in the aorta, because this Sapien 3 and was everything correct with no any dissection or any damage, and the patient did well during follow-up. So the learning points open for discussion in this case is how to avoid patient malfunction to prevent device embolization. And the second one is how to manage device embolization in TAVR. If you want, we can discuss here these points and then move to the paravalvular leak cases.
Excellent case, Professor Sanos. We do have very similar case actually 1 year ago, and this is a problem with the balloon expandable valves. That if the pacemaker just failed, you end up with the embolized valve. Our lady, I don't know whether your patient had a significant tricuspid valve disease, significant tricuspid regurgitation. I think in our case, the problem of pacemaker failure was that she had a significant tricuspid regurgitation, and the pacemaker, the transit pacemaker wire was not properly placed, and it was dislodged during the rapid pacing step. So our only advice is that if you have a patient that would receive a balloon expandable valve, preferably either go for LV pacing through the stiff wire, or use a transit pacemaker with an active fixation to avoid this complication. But it's an excellent case, and I do congratulate you with a perfect management.
Yeah, it's okay from our journal. It's not my case, so I don't know about that tricuspid insufficiency. But I agree with you. This not happen with a self-expandable valve, at least during the deployment. And that idea about using the left ventricular guide wire is very good. They are using this minimalistic approach. They are using more and more. For our audience, you have to use the positive in the groin using one needle, and the negative using the center of the guide wire, and then the isolation of the wire is provided by the valve, or if you are doing a pre-dilatation or post-dilatation with the balloon system. And usually they are not complaining about any loss of catheter, but this is unipolar pacing. Using this idea, they have developed a new left ventricular guide wire. It's called the Watson, and the same guide wire provides you support and also bipolar pacing. So maybe it's a good idea to try to avoid this malfunction of the pacemaker.
Okay, thank you. It is a challenging case, but you think part of the dislodgement may be due to the distribution of the calcification in the leaflets and in the non-coronary leaflets? Do you think when you have what's called circular distribution of the calcification may prevent something like this for the low-mounted embolization device?
I don't know. Maybe they are using unplugged stiff wire that is not very common nowadays. Probably is better with Confida or Safari in order to obtain better support and complete, not to have these extra bits. And the other thing is that if you don't have this fixation of the lead, maybe during this rapid patients, the lead can move and lose momentaneously 1 or 2 bits that in a balloon expandable is very, very dangerous.
Dr. Jose, just small comment about the pacing malfunction. I think this is it's very important to study the patient very well before doing the TAVI, that you have to know the anatomical features of everything, of the right side and left side, before starting the TAVI procedure. That, as Dr. Ahmed said, if we have, for example, a problem with the tracheal valve, like a severe tracheal regurgitation or a right ventricular dilatation, that will make easy movement of the pacemaker wire from the right ventricle and loss of pacing. So in this condition, we can decide from the start either to use the left ventricular wire as a pacing technique if we are going to use a balloon expandable valve that is dependent on a rapid pacing protocol, or we can decide from the start to use a self-expandable valve which can be deployed and implanted without this rapid pacing protocol. I think to avoid this problem is much more important than in such a case.
I agree with you, because tricuspid insufficiency is very common in TAVR patients. You have moderate to severe insufficiency. This could provide a problem with that, as you mentioned. I agree with you.
Dr. Jose, do you think that this complication or device embolization is unavoidable? That's to say, if you are doing persistent pushing down to the device, and if it happens with pacemaker loss or pacemaker failure, you can prevent this embolization upward while you are doing some pressure and pushing down the device?
Yeah, I agree. If you have predictors that you are going to have problems with this valve, I will go for a self-expandable valve for sure.
Yes.
I think you have another case, Jose.
Yes.
Okay.
In fact, it's two cases published also last year by Sean Conte and co-authors. It's plugging paravalvular leak in transcatheter aortic valves. The first case is a 70-year-old patient with also severe symptomatic aortic stenosis, with high risk. It was a high-risk patient with a lot of comorbidities, so they decided to TAVR with a self-expandable 34 millimeters Evolut R valve. The patient did well at the beginning, but worsened during follow-up, and after 12 months, he has a recurrent heart failure, and that was the reason. Two leaks in the TAVR, with worsening also in the left ventricular function and moderate dilatation. So they decided in the procedure first to pass this leak with a AL1 catheter and hydrophilic wire. But after that, they tried, because the defect was very, very big. They decided to use an unplugged vascular plug 3, and they needed a 6 French catheter. They couldn't pass with this delivery shift, so they used a 4 French glide cath to enter in the left ventricle, and using it, looping the wire, and then pass it back through the valve until the ascending aorta to obtain more support. And then again, when they try to advance the delivery sheath, they could go through the leak, enter in the left ventricle, and deploy a 12 by 5 millimeters unplugged vascular plug. Here we have some of the images. So in the first part of the video, where I want to see the guide wire in the left ventricle, then in the ascending aorta, this is the delivery system using the transfemoral access, and we can see finally a very big unplugged vascular plug sealing the major defect. So here we have the result. sealing almost completely the major leak with very good result, and the patient did very well during follow-up. And here we have the second case. It's a 77-year-old patient with also severe symptomatic aortic stenosis, high risk. They use a balloon expandable valve, a Sapien 3 of 26 millimeters, with a very good result at the beginning with just mild paravalvular leak. But again, during follow-up, after 1 year and a half, the patient had a moderate to severe paravalvular leak with left ventricular ejection fraction reduction and again heart failure. So they presented the heart team, and the decision was made to perform also a paravalvular leak closure. Here we have another image of the huge leak in the left ventricle. So for this case, they use a JR4 catheter and again hydrophilic wire. And again, the problem was trying to advance this 6 French catheter for the unplugged vascular plug 3. So for this case, they use another strategy. They use then, when they cross with the hydrophilic wire, they use unplugged leg 1 to exchange this wire for a Landerquist, the high support wire. Then with this Landerquist inside the left ventricle, they could advance the delivery sheath and deploy the unplugged vascular plug 3. Here we have first the hydrophilic guide wire, then a changer for the Landerquist. And here we have the vascular plug in position with very good result. So 2 different valves, 2 different strategies. This is the learning points of the case. First is to identify very well when a paravalvular leak is severe, because it's associated with a high mortality, as we have seen in most of the trials. Also, detect the problem of this leak, because if we have different problems, we have different solutions, as we are going to comment now. And the other thing is how to gain support for unplugged vascular plug 3 when we have a large defect that we have to cover.
Thank you, Dr. Moreno. Congratulations for the 2 challenging cases. My question about the second case, do you think that we may try in the second case to do a balloon dilatation or post-dilatation of the valve first? It can help to decrease this paravalvular leak for the second case?
Not only for the second, but also for the first one, I think. In my opinion, first, I will try to use balloon post-dilatation in a TAVR, trying to reduce probably this malposition of the valve, and trying also to reduce the size of the leak. Because if you have then with the transesophageal echo indirect less leak, then you can change your strategy and not need this kind of support, and maybe just use unplugged vascular plug 4. That maybe you can use 4 French or 5 French catheter. So I think the first thing is you have to evaluate the reason of the leak, and if the reason of the leak is bad expansion of the TAVR, for sure going first for pre-dilatation. I think it was probably the reason in both cases, so I will go in the both for a dilatation.
Dr.
Jose, I would like to ask you a question as regard this late presentation of aortic regurgitation. This is a very nice cases, and we have to learn a lot from these 2 cases, as that severe aortic regurgitation may develop later on. We usually think that even if we have mild or moderate aortic regurgitation as a start, this will decrease over time. But this was not the situation in such case. The aortic regurgitation increased over time. What do you think the cause of this progressive aortic regurgitation in such two cases? Do you think that the valve was undersized, or the annulus was not circular, or is this a case of bypassed aortic valve, for example, or what was the etiology of such progressive aortic regurgitation in such case?
Yeah, unfortunately, we don't have all the data of these two cases, so we don't know the result after the procedure. But I think for sure in the second case, I think is probably the 26 is short. Probably it will have to be better at 29. And in the first one with the core valve, it's 34 millimeters. So we don't have more than this in core valve. And it's very rare in this case, because one should expect with this nitinol continue expansion and try to cover all these possible gaps. So I don't know exactly what happened here, but it's very strange that with the time and after 1 year, the patient passes from mild to severe paravalvular leak. It's very, very rare.
So if there is no burning questions from the panelists, allow me to thank you, Jose. Hamdi, you have a question?
Yes,
Okay.
yes. Dr. Jose, I think one of the causes of these paravalvular regurgitation, especially if it is delayed after 1 year, may be due to low deployment of the valve. I have a case like this in 2013. The patient arrested during deployment of the valve, and we did resuscitation for 30 minutes. She had a successful result, but with mild regurgitation. But after 1 year, she developed moderate to severe aortic regurgitation with frequent heart failure, hospitalization, and the balloon, when we did redo TAVI, the balloon didn't work well, and we implant another Sapien XT valve at a higher level, and she was doing well.
Yeah, but even with this, with the core valve is very stable. So if you have a low implant at the beginning, probably you will have this moderate to severe paravalvular leak from the very beginning. But with the time, it's very rare when all this fixation, the industrialization, also the nitinol expanding, that after 1 year, the valve is going to go down. So again, we don't have the image from the deployment and the immediate results, so we cannot evaluate or compare the two images. So there was cases from our journal, and we try to use them for the public for educational purpose. But for sure, we need more data.
Okay, so thank you, Dr. Jose, and allow me to stick to time. Thank you very much for this very educational, interesting cases. And now we have a 30-second break to come back with Julia Grapsa and another challenging case.
Thank you very much.
So my name is Julia Grapsa. I'm the editor-in-chief for JACC Case Reports. I'm working at Guy's and St. Thomas's. And I will present the case of thinking out of the box, that's the title, because it's a bit challenging. So a 74-year-old patient who was admitted in the cardiology department for heart failure symptoms with shortness of breath. He was in New York Heart Association class 3 and bilateral pitting leg edema, hemodynamically stable with a blood pressure of 111 over pacing. So the patient from the background has type 2 diabetes.
Go ahead.
So the patient has chronic kidney disease with EGFR of 49, and he had the previous MI with angioplasty at the left circumflex 4 years ago, pacemaker implantation 3 years ago, and another stent to the LAD 1 year before this admission. So he has ischemic heart disease, CKD, hypertensive. He has also a pacemaker replacement. And he's on appropriate medical management. He's on bisoprolol, ramipril, maybe not the highest dosages, but we start from this dosage and then we titrate the patient, spironolactone, atorvastatin, aspirin, clopidogrel, furosemide, and his diabetes remains well controlled on insulin. So the patient initially had when he came to emergency department, had blood results with a creatinine of 143, BNP was 3,500, and his troponin levels were normal, and his chest X-ray demonstrate pulmonary congestion. So the first line test that we are obtaining will be first a transthoracic echo plus minus a transesophageal echo. And in order to help you, this is the video from, or one clip from the transesophageal echo, because the transthoracic echo demonstrated significant dilatation of the LV with the end diastolic volume of 82 mLs per meter square, because we always index that to the body surface area. And the patient had an ejection fraction of 45%. Because he had from the previous stents inferolateral and inferior wall hypokinesis. And you can see because of the inferolateral inferior wall hypokinesis, his posterior leaflet is retracted. So this is quite common to happen. And therefore, he has severe functional mitral regurgitation with an effective regurgitant orifice area of 0.35 centimeters square. And he has also significant severe tricuspid regurgitation. His left atrium and the tricuspid annulus are dilated. Just to mention that when we have dynamic mitral regurgitation, we will try to bring the patient to his dry weight and then repeat the echo. That's the first thing to do. And that's why we treat the patient with IV diuretics to reach his dry weight and then repeat the echo. And we also did the coronary angiogram to make sure that the stents were patent and there was no ischemia substrate to justify the heart failure, of course. So we discussed the patient at the MDT. Here, the major problem is that it's a severe coaptation defect of 2 millimeters, and you can see that the posterior leaflet is retracted, and it's quite short in length. So first of all, the patient was of very high risk, Euroscore of 8%, because they thought that he would need tricuspid surgery as well. And he had the function and severe pulmonary hypertension of 80 millimeters per mercury, his RVSP. Cardiac resynchronization therapy was not indicated because his ejection fraction was 45%. And the clinical criteria for a mitral clip to reduce significant mitral regurgitation were met. However, to cut the long story short, the authors of this case started the patient on levosimendan. And this is because they thought of levosimendan combined with diuretics in order to have a long-acting inotropic effect and vasodilate effect in order to reduce practically the volume of the LV. So levosimendan is well known to decrease the LV afterload. It interferes with neurohormonal mechanism and practically decrease the level of BNP. That has as an effect to try to reduce the volume of the LV. And if you can see, this is after third infusion of levosimendan, there is significant decrease in mitral regurgitation severity with regards to an orifice area of 0.27 centimeters square. So this is remarkable. But the question is here, if the patient we left him on levosimendan and he goes home, the MR will come back into the severity degree. And you can see here when we did the authors did 3D TOE post levosimendan that there was significant reduction in mitral regurgitant severity, and they did 3D TOE in order to help them calculate the mitral annular size and to demonstrate that now the annulus was such and the left atrial volume was reduced and also the left ventricular volume in order to make sure that this could be grabbed by a mitral clip. So here is the proof that there is significant improvement of coaptation. And also you could see even reduction of tricuspid regurgitation. So just to be shorten my presentation and to reach the take-home messages, the authors here, they performed one mitral clip 1 month after the last levosimendan infusion. 2 clips were implanted finally in order to achieve no residual regurgitation or even stenosis on the transthoracic echo post-procedure. So here we have a case that we see very often. 1 week after we saw this case, we discussed the clinical case at St. Thomas's, that the patient had all the clinical criteria fulfilled for the mitral clip procedure, but anatomical criteria were not met. And here we describe something out of the box in the sense that we could start diuretics and levosimendan to facilitate the procedure and the patient to go home without heart failure. So thank you very much for your attention. I apologize for this connection difficulty. Thank you.
It's okay. Thank you, Julia. And I leave the stage for the panelists. If there is any questions, Dr. Hamdi, Dr. Salim, Dr. Jose. The mic, unmute the mic. Unmute the mic, please. The mic.
So we have also a question from the audience. When do you think is the best time to perform the mitral clip procedure after levosimendan administration? Thank you, Mohammed, for asking this. Practically, when they saw it was the cutoff of the reduction of the LV volume, and practically the authors, they used the mitral annular plane from the 3D TOE to achieve the best positioning of the mitral clip. And I think that was the right time to perform the mitral clip when the patient was completely offloaded, back to the dry weight with IV diuretics, with the levosimendan, and then grab the leaflets and have a successful mitral clip. Your comments?
Dr. Hamdi, can you unmute the mic, Dr. Hamdi?
Okay.
Yes, some problem. Can you hear me now?
Yes, it's okay.
Yeah, do you think, Dr. Julia, this is a transitional zone for the levosimendan will be for most of the cases in the future to prepare some difficult complexity of the mitral valve apparatus for mitral clip?
So yes, I think this is the first case that they used levosimendan in order to try to reduce the volumes to facilitate the procedure. And I think that up to, we started with the Everest criteria, then we started actually accepting more patients. So now we see more and more that we are thinking of how to save our patients rather than going with the protocol. And this is a very important teaching point. So we might use infusion of levosimendan or either inotropic agents to facilitate our procedures.
Any other comments?
Yes, Dr. Ashraf. Thank you, Dr. Julia, for this very interesting case. For me, it looks very plausible that the severity of the mitral regurg could be decreased by the infusion of levosimendan. But what about the explanation of this tremendous decrease in the left atrial volume? It could be acute like this for very significant decrease in the left atrial volume. What do you think about this?
So that's a great question. Thank you for that. So levosimendan, since it's a vasodilator and decreases practically the natriuretic peptide levels, then it would decrease also the pulmonary capillary wedge pressure. And that means the left atrial pressure coming from the mitral regurgitation. With the reduction of the mitral regurgitation severity, then possibly there was an effort of the left atrium to try to somehow, if we call it reverse remodel, in the sense though of reduced pressures into the left atrium, because left atrium has the phases of distension. And I think because it was acutely distended from the high pressures, then it tried The difference is about 8 to 9 mLs per meter square. So it's not that it went completely back to normal. It is distended, but maybe not that distended in order to facilitate the procedure. And I think with the levosimendan, it makes sense because it reduced significant capillary wedge pressure, left atrial pressure, and then slightly the volume as well.
Thank you. Thank you, Dr. Julia, and thank you for thinking out of the box and giving us this interesting case. And I think we are appropriately in time, so we can have a minute for break and come back for the second sessions. And it is as interesting as the first one, I promise. Thank you. Waiting for you to join you.
Hello again, everybody. We are now streaming for the second session from JACC CardioGO Casebox. I think we fulfilled the aims in the first session. They were very interesting, interactive, and educational cases presented by Professor Hazem Khamis, Professor Jose Carlo, and Professor Julia. And the panelists were Professor Nabil Farag, Professor Hamdi Sliman, Professor Muhammad Selim, and Professor Ahmed Al-Sayed. I think now we will move to the coming also interesting session, which will be also had a great cases prepared by Professor Karim and Professor Jawed. We will start now by the first case by Professor Karim Mahmoud. I think it will be a case of infective endocarditis, and as we all know, infective endocarditis is a fatal disease, and we have to be ready with all strategic tools for investigations, for management to counteract this major fatal problem. Also, it's a great pleasure to have with us today Professor Atif Al-Bahari, Professor of Cardiology, Bursaid, as a great panelist, and Professor Muhammad Mustafa Ansari also is with us here, and we will have a coming case by Professor Jawed. Please, Professor Karim, we will start now.
Thank you, Dr. Sayed. First of all, I'd like to thank JACC CardioGO committee on this great event. So, as you mentioned, Dr. Sayed, my case is an infective endocarditis case. He is a 22-year-old male patient. He is driver and single. He has no special habit of medical importance. In September 2014, he has an aortic valve replacement with a mechanical valve on a top of some symptomatic bicuspid aortic valve stenosis. 1 month later, the patient started to complain of fever reaching 38 degrees Celsius with rigors, vomiting, diarrhea, and dyspnea on minimal exertion. And he was diagnosed to have an early prosthetic valve, aortic valve endocarditis due to aortic root abscess and dehiscence of the aortic prosthesis and severe paravalvular leakage. So at this time, unfortunately, his blood culture revealed Pseudomonas. So he had a redo aortic valve replacement at November 2014 with plication of abscess cavity, and he received antibiotics in the form of imipenem, celestine, and ciprofloxacin for 6 weeks. He improved actually, but the post-operative transesophageal echo showed a small residual cavity, and there is no evidence of relapsing infection at this time. So after 1.5 years, on January 2016, he came for follow-up. He had no history suggestive of relapsing infection, no fever, and no other symptoms. His general examination, his blood pressure was 120/80, his pulse was 82 beat per minute, regular. He has a normal jugular venous pressure and chest and abdomen examination. His precordial examination showed a median sternotomy scar that healed by primary intention. The apex is felt in the left 6 intercostal space outside the mid-clavicular line with systolic expansion. He has a normal first heart sound with a closing metallic click of the second heart of the aortic prosthesis. On the base of the heart, we can constatate ejection systolic murmur grade 3/6 together with early diastolic murmur. And this is the ECG that shows the evidence of this is a sinus rhythm with evidence of left atrial dilatation and left ventricular hypertrophy. And this was his echocardiography. As you can appreciate in this thoracic echocardiography, we have the aortic prosthesis that looks moving well, with this large cavity at the posterior aspect of the aortic root. And this cavity showed color flow, suggestive there is a communication between this cavity and the surrounding structure. Here in this parasternal short axis view, we can appreciate this is the prosthetic valve, and this is on the level of LVOT. We can appreciate the presence of a faceless communication into the LVOT. And here is the valve. This is a cavity. The cavity is encroaching on the left atrium. So we went into the transesophageal echo, and in the transesophageal echo, we can appreciate this large defect between this large cavity and the LVOT. And in the short axis, we can appreciate this large cavity at the posterior aspect of the aortic root, with a large communication with aortic root and the LVOT. Here is we can define the better the communication between the aorta and the LVOT. Here is the cavity, and this is the communication with ascending aorta, and this is the large defect with the LVOT, and we can see how the flow go into this cavity from the aortic root and go into the LVOT through the large defect. And this is again a zoom view on the inlet and the exit of this fistulous communication. And this is the hemodynamic. We have this is a pseudoaneurysm. This is a characteristic pseudoaneurysm. We have the to and fro flow and the inlet of the pseudoaneurysm. There is an increased gradient at the aortic valve as seen in this transgastric view. However, this might be due to the increased flow across the LVOT. In the 3D echocardiography, we can appreciate again the cavity encroaching into the left atrium, and here is the mitral valve, here is the aorta and the LVOT, and here is the cavity with this large defect between the cavity and the aorta. So the most important question is now, was it a new infection? We did a workup for these patients, including the usual labs that give normal total count and normal C-reactive protein. The blood culture at this time was negative, and serology also was negative. And the patient experienced a fever or a communication from new infection. So this was a new infection. And we workup with the authority that confirm our findings in the echo, advanced echo, with the presence of a large defect and with the aspect of the aortic root, and this is the measurement of the defect. Here is the cavity, here in the CT. Again, this cavity, the CT has an important role to detect the extent of the cavity at which level of the aorta. And the cavity is reaching up to the aortic arch, as you can appreciate here. Here is again the cavity down. Here is the level of the pulmonary bifurcation. The cavity is still present, and the cavity here communicating with the LVOT that is seen also here in this view. So the plan of management for this patient was sent to surgery, and the surgery here was repair of ascending thoracic aorta with excision of this cavity and the replacement of the ascending aorta. And here is some views from the surgical theaters. They start to excise the cavity, and this is the defect that we see in the transesophageal echo. They did a complete excision for this cavity and replace the aorta with this synthetic graft. The end result was fine despite this. I want to remind you, this is the third surgery for this patient. However, the post-operative course for this patient was fine, and he was discharged safely. And here we can appreciate the fact that aortopathy is common in the bicuspid aortic valve. It might be due to genetic predisposition or molecular pathways, or due to the hemodynamic turbulence that occurs with bicuspid aortic valve. Also, there is multiple risk factors that can happen in the bicuspid aortic valve and can cause this progression of the aneurysm in the bicuspid aortic valve, such as age, diabetes, hypercholesterolemia, aortic regurgitation, and smoking. And this is the indication for the surgery for a bicuspid aortic valve. However, here we have a different situation that is different from the common indication for the bicuspid aortic valve. We should remember that infective endocarditis in bicuspid aortic valve is not uncommon. It occurs usually in younger patients with there is a higher rate of pre-annular complication. However, no significant increase in mortality may be due to the patient is younger in age. And this is a study that published in JACC at 2018 that showed that the bicuspid aortic valve is associated mainly with the strep viridans, with the odontical focus. The cardiac complication in the form of pre-annular complication is more, and the cardiac surgery is more in these patients. So to conclude, this is our patient with bicuspid aortic valve that underwent aortic valve replacement and had early prosthetic valve endocarditis. He then has a redo aortic valve replacement, but due to aortopathy, he had this large aortic pseudoaneurysm, as we can appreciate in the previous investigation. So this is our conclusion, that bicuspid aortic valve is associated with aortic valve disease and aortopathy, and the infective endocarditis in the bicuspid aortic valve is associated with a higher incidence of pre-annular complication. And in this case, aortic root complication tend to progress even after resolution of the infection due to progressing aortopathy. And thank you so much.
Thank you very much.
Okay, Dr. Atif, thank you, Professor Karim, for this very interesting case. And I think we have a lot of discussions around this case. I'd like first to welcome Dr. Ali Zaini. He is also joining us now. We are happy that he is with us today. And I think we will have a great discussions also from him. And now we will start the discussions with our eminent professor, Professor Atif Al-Bahri, the Vice President of IAVA. He will start the asking Professor Karim. Professor Atif.
First, I welcome all of you, Joel Gilbert, Julia Grabsa, and Dr. Hani, Sayed, Dr. Karim. And thank you, Karim, for your case. I have two short questions. What would be the proposed etiology of such complications, and what is the good workup needed to exclude new infection in the future?
Thank you, Dr. Atif, for your nice question. First of all, if I faced this complication with a progressing aortic root cavity in a patient with a redo aortic valve replacement, first I should exclude the infection. The infection and the new endocarditis can occur and can be responsible for this complication. However, in these patients with bicuspid aortic valve, aortopathy and weakness of the aortic media can also be responsible for this complication. But as you mentioned, we should first exclude the infection. And this make us go to the second question regarding how to work up to exclude this new infection. Actually, as we mentioned, we should collect the clinical data of the infection. We have what is called the modified JACC criteria for that depends on the pathological, culture, echocardiographic, and laboratory workup. So blood culture is important, serology is important, all were free. Laboratory markers also like CRB, the total leukocytic count, the ESR, the clinical characteristics of infective endocarditis, I mean that rose spots, the Janeway lesions and ocular nodules. We should search, and of course, the embolization. We should search for all evidence of infective endocarditis. It's a systematic disease. It is not confined to the heart, and we should do an extensive workup for these patients.
Do you have any study at your department regarding the incidence of and the predictors of the aortic root abscess, Dr. Karim?
Thank you, Dr. Atif, again for this question. Actually, we did a study in our centers regarding the incidence of aortic root abscess in the patient with left-sided infective endocarditis. And the incidence was about 21%. We have about 61 patients with aortic root abscess. The incidence among the patients with left-sided infective endocarditis was 21%. The predictor here was the male gender, the presence of prosthetic valve mechanical prosthesis, because most of our Egyptian population have a mechanical prosthesis. The congenital heart disease, and especially the bicuspid aortic valve, is a predictor for that. The presence of an elevation of a CRB also is a marker. The echocardiographic predictor, such as the presence of the prosthesis, aortic paravalvular leak, and aortic vegetation, all of these were predictors of aortic root abscess in our region.
So it's a very high incidence, huh?
Yes, we should look for aortic root abscess in every patient with aortic prosthesis, and because this complication increase mortality and it have an impact on the prognosis. So yes, it's common complication in the patient with infective endocarditis, and our patient usually present late. So this gives the time for the aortic root abscess to develop and enlarge, and to have the full-blown picture on presentation to our facilities.
Thank you very much, Dr. Karim, for your presentation and your answers.
Thank you, Professor Atif, for this elegant questions and discussion. I'd like here to ask my dear colleague, Dr. Hani. I know he's one of the eminence in the 3D echocardiography, and I'd like to take the chance to ask him about the role of the 3D echocardiography as one of the tools in the strategy of managing infective endocarditis, and also in such a patient with bicuspid aortic valve. Can you give us the strict rule of the 3D echocardiography, Dr. Hani?
Thank you, Professor Farag, and thank you so much, Karim, my friend, for such a great presentation, and thank you for showing very nice 3D images. I was very happy to see these images. So back to the question, yes, of course, TE, even the 2D has a crucial role, even like all the ways guide you at the end to send the patient for TE. But 3D, TE has a lot of added values in terms of determining the extension of the affection. 2D can readily diagnose the vegetation or there is a leak, but 3D can give you a holistic approach in diagnosis, and we could see very nicely from Karim's case that 2D defect was there in the 2D, but by the 3D we could see the hole itself, and you can actually size this using the NPR mode on the machine or offline as the same way like the CT guys are doing. So it's very helpful, especially for patients who are not capable of having CT because of renal issues, for example. So in my institution, about 30% of the referrals are to exclude infective endocarditis. I'm currently working in a tertiary center at a transplant center as well, heart transplantation. So there is a high incidence and like a big fear of infective endocarditis in almost all patients with fever, especially after cardiac surgery or pre and post transplantation. So we're getting this every now and then, and the yield of 3D TEE, as I said, is not only to diagnose the problem, it is also to show you the extension of the problem, how this affects the valve. Is the valve repairable or not? Whether the vegetation is 1 or 2 or 3. Is it big enough to just be removed and preserve the valve, or it's affecting a lot of multiple areas of the valve, that means the decision is we'll just go and replace that. So it has a lot of added values, especially not only just by looking at the distribution of the vegetation or the affection, but also for the sizing, as I said. In this particular case, I've seen the major hole that leads to the big aneurysm, and there was another hole with to and fro flow from above the valve. So there was a hole below the valve, and there was a hole. If you can go back, Karim, for the same images, for the 3D, for the 2D one. Yeah, the one before that. Yeah, can you let it run, please? Yeah, run. Yeah, so you can see here in the right-handed images, there is a hole down below the aortic valve, and there is another one just above the aortic valve. And this is another communication. So it was not only between the LVOT and the cavity, there was also another entry point between the cavity and the aortic root.
Yes.
Yeah, but that was very tiny. And I was also surprised clinically that this patient has no murmur, and the pulse pressure was normal, like 120/80, and that, if it is the case, and I'm sure it was.
Oh, he has murmur. He has actually murmurs. Yeah.
He had murmur.
Yeah, he has murmur.
Yeah. Okay. So the pulse pressure was like the blood pressure was 120/80.
I know this was a little bit strange. Yeah, but yeah. In the usual cases of this severe paravalvular leak, we expected to have a wide pulse pressure. Yeah, I know that, but this was the case in this patient.
Exactly. This is what I'm saying. I'm stressing that imaging is crucial. So in clinical basis, you may miss like the wide pulse pressure, although there is significant leak, but this leak is not really paravalvular. It is between a closed space, more or less closed space between the LVOT and the cavity, and it goes back to the LVOT. And the only communication between the root and the cavity is tiny. It's very small. And this is, I think, that's why the pulse pressure was not really affected. And you may get a murmur because this to and fro through the small cavity. So yes, 3D is very helpful, and that case is very clinically relevant. That even in the absence of clinical signs of infection, imaging is very crucial to give you the diagnosis. Thank you, Karim.
Thank you.
Thank you, Dr. Hani, for these very elegant comments, and I think you gave us a very nice picture about the importance of the 3D in the strategy of management of such fatal cases. It will help us to take the decisions, to direct the patient. Of course, it is very important. Now, I'd like to give the mic to Professor Muhammad Ansari. If you have any burning or any comments that will add to the case, please, Professor Muhammad.
Actually, I would like to thank Professor Karim for the nice presentation and Professor Hani for the discussion that cleared up everything. But I just wanted to point out an issue about the changing trend in the developing countries about infective endocarditis, which is happening because we had more number of rheumatic heart diseases in the past, but nowadays we are seeing more in the congenital heart disease patients. So I wanted to ask Professor Karim if he thinks that is there any special need to focus on congenital heart diseases more in the issue of infective endocarditis in developing countries, or do you think we have enough knowledge and experience in these cases?
Thank you for your question. Actually, from our registry, we see the infective endocarditis in both cases, rheumatic heart disease and congenital heart disease. Till now, we are seeing more among patients with congenital rheumatic heart disease. This might be the rheumatic heart disease is still present in our community. However, my expectation that the incidence of congenital heart disease will be rising in the next decades due to the advances in the management of the patient with the congenital heart disease, and the more and more we are getting encounter with a good patient, the grown-up congenital heart disease patient. So every now and then we are seeing an increasing number of congenital heart disease patients with infective endocarditis. The next thing that I'd like to point it is a special category, which is the patient with IV drug abuse and the patient with the lead endocarditis, the device endocarditis. These are a substantial increasing category of patients with endocarditis, and we will face more and more patients with this patient in the next case.
Thank you, Professor Karim, for this descriptive answer. And I don't know where is Dr. Ali Zaini. We would like to let him join, but till that, I'd like to ask Professor Julia, what is the highly recommended cascade of investigations? As you know, we have to be as rapid as we can for that such subsets of patients. So what is the optimum recommendations for cascade of investigations for patients, imaging investigations for patients with infective endocarditis?
So thank you very much, El Said, for this question. At St. Thomas's, we are a center for endocarditis, and what we are doing is we are trying to be quite proactive. So a patient comes, if we verify that there is a suspicion of endocarditis, then we aim to get them to theaters within 24 to 48 hours. Because we have seen that patients, of course, that they are operated late, they don't have, they have a lot of complication or even high rate of mortality. They also, if needed, as Hani correctly said, imaging is very important with the TOE. If TOE does not show anything and the patient keeps being septic, then CT PET, which is now included in the ESC guidelines. And we use a lot CT PET to confirm endocarditis and then again operate early. But all these investigations should not delay. I will only mention, for the sake of time, that we had one event during the COVID situation that the report from the echo to escalation of antibiotics delayed by 3 days, the escalation of antibiotics to surgery delayed another 3 days, and unfortunately, meaning the patient survived. However, he had some complications. So, that was due to the COVID whole panic and everything. So this ideally should not happen. Everything is a matter of hours.
Okay, thank you, Dr. Julia, for your comment, for your answer of this question. And I think for the sake of time and to let the mic now for the coming case, please, Professor, thank you, Karim, for this elegant case presentations, for answering all the questions you face. And now we have to shift to the coming case, and I think it also will be very interesting case by Dr. Joel. He will present us an uncommon case of iatrogenic VSD, what we will do. Professor Joel, please.
Well, thank you for giving me the opportunity to speak at this wonderfully educational meeting today. I've got a very interesting case to share, and one of the joys of being part of the JACC Case Reports team is that we get to see some of the the weird and wonderful, the first in man cases that go on around the world, and have the opportunity to share one of these today. So I'm an interventional cardiologist in Cambridge, but I'm actually going to be sharing a case that Dr. Rodriguez and his colleagues undertook in Brussels, which was they believe and we believe to be the first case of its type. So this is percutaneous closure of an iatrogenic inlet ventricular septal defect in the AV canal, and I'll just present the case to start with. So this is a 45-year-old lady who has a history of a partial AV septal defect. She had an ASD, an ostium primum ASD, and mitral cleft, and she'd been through multiple surgeries. And she presented on this occasion at the outpatients clinic 2 months after she had a St. Jude mechanical mitral valve prosthesis with breathlessness and an examination that revealed a parasternal murmur. So to give some past history, the patient had had a first surgery with closure of the ASD at age 27 and repair of the mitral cleft. And then 5 years later, for mitral regurgitation, she'd had further mitral valve repair and a tricuspid annuloplasty. At 38, she'd presented in complete AV block and had a dual chamber pacemaker. And then she represented relatively recently before this case with recurrence of her mitral regurgitation. And at this stage, the team had decided that they should replace the mitral valve with a mechanical prosthesis. That was her third stenotomy. She had a fairly difficult post-operative period. The team reported that this was complicated with pneumonia, and she also had atrial fibrillation, which was poorly tolerated. But nonetheless, she went home relatively well afterwards, was briefly well, and then represented with further breathlessness. So echocardiography, and the case report doesn't have the pictures of the echocardiogram, but what it showed was that there was an intraventricular shunt located beside the annulus of the mechanical mitral valve. The patient underwent right and left heart catheterization, and this demonstrated that the shunt ratio was 1.7. So that's considered to be a significant shunt. So the patient was discussed in the MDT, the heart team, and the decision that was taken in that forum was to attempt a percutaneous closure of this hole. The reasons for this were given that they wanted to avoid a fourth stenotomy for this patient, but they made the decision despite a clear lack of data for this particular indication. Obviously, partial AVSD occurs. United States data would suggest that this is 1 in 2,000 live births, so relatively rare. And then down this line, this is going to be a rare as hen's teeth, we would say in the UK, complication. So they were acting without clear data to guide them. But that was what they decided to do. So in their report, they shared some of what they did. And, in some senses, this is a very useful report because it shares some of the technical aspects of closing a VSD that you would do in many circumstances. So they undertook a retrograde approach to cross the VSD. They went from the left femoral artery and crossed the aortic valve with an 035 guide wire and a 5 French AR2 catheter. They selected the AR2 because the angulation helps in their experience with crossing. In Cambridge, we would potentially use that guide catheter as well as perhaps sometimes using a hockey stick as an alternative. But there are lots of options there, and that's very much the personal approach. They crossed the VSD retrogradely and directed the guide catheter into the pulmonary artery, and then they formed an AV loop by passing a further multi-purpose from the right femoral vein and snaring that in the pulmonary artery. And I will just show you that in a moment. Here we go. So on the panel on the left, we can see the guide wire from the AR2, and it's been snared, and we can see that snare is pulling the guide wire down from the pulmonary artery down to the sheath, and that creates an AV rail, which is going to allow you to deliver your device to close it. It's very important that this is snared wherever possible in the pulmonary artery. The reason is that the snare can capture the tricuspid apparatus and cause problems if you try and snare it within the right ventricle. So getting it well up away from all of that, all of those important structures is really important. So on the right panel, we can see here that they moved on a bit, but what they attempted to do was the standard approach, which is an anterograde approach to give the delivery sheath. So they left the AR2 catheter in the left ventricle and attempted to manipulate a delivery sheath up. The idea being that you leave as little wire exposed to the defect as possible whilst you're manipulating things to minimize the risk of a cheese wiring effect of the wire or making it worse. But in this case, they couldn't deliver the delivery sheath to the VSD because it became caught up in the tricuspid subvalvular apparatus. So instead of that, they switched to a retrograde approach here. They moved their AR2 catheter into the venous side and move the delivery sheath forward from the other side. And I will move the catheter on. So once they'd got that, they took a JR4/5 French guiding catheter retrogradely through the aorta to the site of the lesion, and then they took a picture of it to give themselves, using quantitative angiography, a very clear idea of the dimensions of the defect. The authors here say that they did look at this with transesophageal echocardiography as well, but they felt that they couldn't, because of the position of everything, they couldn't get accurate sizing that they needed. I think in my experience with these, we spend a lot of time looking at both angiographic and transesophageal measurements to make our decisions. So if we move on, they measured the VSD as being 4 millimeters in width and 3 millimeters in length. And because of that, they selected a St. Jude Amplatz duct occluder. That's a device that's been purpose designed for closing PDAs. But as we'll discuss, I guess, a little bit later, there are no specific devices for these indications. It's very much a matter of thinking on your feet and picking what will work. And the reason that they selected this was that they felt that the anatomy and the size was most suited. In this case, the 6'4" size has a 6 millimeter waist that's 4 millimeters long, so it's not going to be too long in the relatively short defect. And 6 millimeters, it's going to have plenty of room to expand into that, and with the nitinol frame, it would sit nicely. This particular device has 12 millimeter discs, and the feeling was that with a small device like that, rather than some of the larger devices that are designed to close, for example, post-infarct VSDs, you're less likely to interfere with the mitral valve prosthesis that's sat there working well at this stage. So on the right screen, we can see on the video that they are essentially, well, we'll wait for it to go back round again because there's a relatively long section, but essentially here what we'll see in this video is that they advance the delivery sheath across the defect, and then once they've advanced the delivery sheath across the defect, they advance the device through the delivery sheath, withdrawing the right ventricular disc. Once the right ventricular disc has been withdrawn, or is out of the delivery sheath, as you can see happening now, and it will form up into its disc, the whole thing can be withdrawn back until it makes contact with the septum, at which point the device is left in place and the delivery sheath is further withdrawn. And we see here on the video that the waist forms up, and then eventually it comes the right disc as well, and it's sat covering the defect very nicely. So once they released the device, they were able to take pictures, and they were able to look at this with echo. And in both cases, they could see that there was no flow across the valve. They could also see that no flow across the defect. They could also see that the device wasn't interfering with the valve leaflets, and you can see that on fluoroscopy. And they were also able to look at that on the transesophageal echocardiography as well. So that's the case, and that's a very nice case that we have the opportunity to look at here. The situation with VSDs is that each one is very unique, and there are very few devices that are going to work in all situations. And I've left some larger VSDs, larger acquired VSDs, such as post-infarct VSDs. There are lots of different options available, and the choice of that is going to depend on a lot of imaging modalities, some of which you can look at before. CT is often very useful in those situations. I'm unclear as to whether there was a CT performed in this case as well to help them decide before they did it. They made most of their decisions based on the angiography at the time. And then smaller defects don't have often specific advices, but the duct occluded 2 for the Amplatzer is probably the device here in this sort of situation or similar situations, which has the most sort of case report evidence to guide it. So I guess some points that we could think about discussion. They undertook percutaneous closure. The other option was further surgery here. What are the long-term outcomes? We don't know what that is. There really aren't any devices in this situation. All of these technologies are orphans, and that causes some difficulty because the FDA The EU CE marks aren't given for these devices for the indications. All choices are always off-label decisions. And last time, this was what one of my colleagues, when I was talking to them yesterday about it, said to me was, in some centres they would use 3D printing in these cases to help plan cases. You can deploy the device and the defect based on the CT beforehand and see how it fits. And that's an interesting thought of something for the future. So I guess I'll turn it over to the panel to see what they think.
Thank you. Great case.
Thank you, Dr. Joe. It's really interesting, very out-of-the-box case. And I think we will have a lot of discussions about, I think the one discussion point you raised, that the percutaneous closure versus further surgery. And I'd like here to take the chance to ask first Dr. Ali not yet joining us, Dr. Ansari. What's your opinion about the percutaneous closure versus surgical closure for this case?
Actually, considering the case and the previous hysterotomy and the high risk of further surgery, I believe a percutaneous procedure can be more favorable, but it also depends on the expertise and the team who is working on the patient. But another thing that we can think about might be hybrid procedures, using different incisions for the surgery. But still, I think it's a matter of team work and to discuss it in a hard team and think on individual cases.
I think that's right, and I think you've got to have a team that's in agreement to do something like this when people haven't done it before. It's a unique decision. I think the other thing here was that effectively this was a shock to nothing. If this hadn't worked, if they'd been unable to close this, that it didn't rule out the possibility of going to surgery afterwards. This wasn't a defect where a matter of hours was going to make a difference between survival or not. And I think therefore they had time to undertake a percutaneous attempt. And then if that had been unsuccessful, if they were unable to successfully close the defect, or it was just interfering with the mitral valve prosthesis, then she still had the surgical option on the table afterwards.
Okay, Dr. Hani, again, the role of imaging, the role of TE and 3D TE in such unusual case. Can you give us your opinion and what you would like to raise in such a case?
Thank you, Joel, for such a very nice case, and this is really challenging. I enjoyed it, although I didn't see any echo. I'm an imaging guy, so
I know. I was really hoping that there would be one. They obviously, you can see in the background on this picture that they have a TE probe down there, but it's in the case report that they gave us. They didn't provide any of the echo images, I'm afraid.
Yeah, and that's why I'm feeling a bit disappointed.
Oh, I'm sorry,
but that's fine. So yes, surprisingly, it might be a bit of like for you to hear from me that I would say guiding closure of this particular defect is very difficult. I guided a lot of VSD closures, but the easiest ones will be those in the middle of the septum or apically displaced VSDs. That would be very easy to close, but such very proximal VSD, especially in the presence of this prosthetic mitral valve, it's very difficult to see using transesophageal echo because this prosthesis will just cast a shadow just behind it, and it will cover the very proximal part of the septum. It's quite difficult. I've just faced a case recently, and it was post-MI, and we really struggled to get like an axis with off-axis images in order to get one without this artifact from the prosthesis. So I really congratulate whoever guided this case. That was very difficult task, and I appreciate how difficult it was. Transthoracic echo sometimes gives you a better view because the shadow will be on the other side of the prosthesis. But overall, assessing the VSDs, is for closure is very well done using TOE, but in the absence of any like prosthesis that can do this. If in children, the echo window is usually much better, and then you can get good images, and you can size that either on the directly on the rendered 3D image, or by using the MPR like the CT, and you can get very good sizing, and you can get the view from the right side surgically oriented. So that's really helpful for the surgeons. I have a comment here because I'm trying to imagine the position of or the location of this VSD, which is just below the mitral prosthesis, and I cannot really imagine where it was exactly, because for me, if you showed me this image, the first thing I will think about without knowing the story, this is paravalvular leak. It just for the mitral valve, because the plug is too close to the mitral valve, and that was another challenge to close it while it is very close to the disc. But I was just trying to convince myself about the location of this VSD. I wrote this 4-chamber view. I'm not sure if you can see it, but this is the right ventricle, left ventricle. Yes. Yeah, here is the left atrium prosthesis, and here is the right atrium. If it is right beside the mitral prosthesis, that means it might be like a Gerbody kind of defect between the LV and the RA. And if it is just more apical than this, because tricuspid will leave this space. Otherwise, if it is here, that means it is not just below the mitral valve. So I cannot really imagine without seeing images where was this defect. And if it was there, actually closing that was very challenging, because we close paravalvular leak, but the access of the blood will be that way, which is easier for the disc. But closing this in that fashion, that manner, that carries a very high risk for touching or jeopardizing the function of the prosthesis. So it was really a challenging case. That's why I'm very impressed that they could close it.
No, they've done very well. I mean, I think the small device that they've taken has helped with that. And I think further to your earlier point, I think this is where, when you're doing these cases, having multimodality imaging, having transesophageal echo, having angiography, and having a CT as well that you can have, in the lab to look at and understand how each structure relates to each other is the only way to do this. Yeah. And we've seen it in a few pictures here, and what isn't clear from the case report is how long this case took, how challenging it really was to manipulate through.
Exactly. Yes.
Dr. Juliet, do you have any opinions about also the imaging cascade in such cases for taking the decision of sizing of the VSD, which happened iatrogenically, to decide which device we will use?
I will only mention one point, El Said, because to keep the time, that as Joel correctly said, congratulations, Joel, that was a great presentation, that 3D printing will have in the future a great value in sizing and also understanding this procedure. So it was so complicated that now we see more often big groups presenting also 3D printing the file, understanding the anatomy and how to guide the procedure better. This is, otherwise I agree with Hani, I agree with Joel. It was a very interesting discussion. This is the only point that I want to add.
Finally, as we are approaching the end of this very fantastic meeting, the joint meeting with the elegant JACC case report, I'd like now to leave the mic for our Professor Ashraf Reda, the president of our association, and also for Julia to wrap up and to make the close-up of this very fantastic, very interesting meeting. And we will ask you all to be future with us. We will have more waves. We will arrange for more waves for the case box joined with JACC case reports. Please, Professor Ashraf Reda.
Thank you, Sayed. Thank you, Julia. It was very interesting 2 sessions. And actually, I like the way of presenting case discussions. This is always very interesting and educational. And thank you, Julia, for this nice cooperation. And I hope in the future we have more interesting cooperative sessions. Thank you all of you. And I leave the closing for Julia. Julia.
Thank you very much for this honor to be here all together. I would like to thank also all the presenters and particularly, the people that were working with Joel, Jose, Mohammed, Ali, and everybody. This is only the beginning. This is what I will mention, because we are friends from before El Said, 10 years now, as you said at the beginning. So I think the future is great and we have a lot of work to do together. So thank you very much. It was great.
Thank you all. Have a nice time and be safe. See you later. Thank you.